and the drugs, the prescription drugs, were getting clamped down on. Their price rose, so the people would pay to get those drugs, and they would have to pay more because they weren't as readily available. As heroin entered the market and subsequently fentanyl, they were cheaper because there's no quality control in their production. There's the expense of getting them here and growing poppies and things like that. So it was substantially less expensive to make the transition, unfortunately, over to more dangerous products like heroin and fentanyl from the prescription drugs. And I think, the really gut-punching part of, the drug market is that people started to say, well, I'm going to take fentanyl, put it in a pill form so it looks like oxycodone, and sell it so I can make the extra money that people are paying to think they're getting a safer product. When in fact, I'm selling them a very dangerous product to make more money.
Thanks. And I know you mentioned that it's hard to wrap treatment services and responses around this because it's always changing. But one thing that Cuyahoga County has going for it is that there is an intense collaboration, that everybody is willing to work together. That's something that we see a lot here, which is pretty awesome. So, Mike Tobin, can you talk a little bit about what the U.S. District Attorney's Office is doing related to the opioid crisis and sort of building solutions?
Sure. So the U.S. Attorney's Office, we enforce federal law, and a lot of that is large-scale drug trafficking organizations. We work with the DEA, we work with the FBI. We're the guys who seek long prison sentences for drug traffickers. And our involvement with this goes back to about 2012, 2013, when we saw a rise in deaths. But it became apparent to us that if you don't address the demand, the demand was driving the supply. One thing you'll hear talking to law enforcement is, we can't arrest our way out of this problem, to the point where it's kind of a cliche. Well, it's a cliche because it's true. We differentiate between drug users and drug traffickers. It became obvious to us that we would still do all the stuff that we always do, trying to interdict the cartels that are shipping it here from Mexico, the groups that are shipping it here from China. But if we were going to help our neighbors, if we were going to help the people who were dying, that we had to think outside just simple, handcuffs and wiretaps. So that led to getting involved with treatment providers, groups like the Adams Board, our hospital systems, the clinic, UH, Metro, St. Vincent, and trying to look at this comprehensively. So there are law enforcement solutions that we're using, but there are also prevention strategies that we're trying to utilize, education, trying to talk to kids, trying to get the hospitals to prescribe fewer pills than they did. Somebody called it the all of the above approach, and I think that's true because we are primarily a law enforcement agency, and we will always be. But unless we all work together to come up with a comprehensive solution, it's just going to be like a game of whack-a-mole where we just take it off one dealer and nothing pops up.
Have you seen a shift in the attitudes of law enforcement from needing to jail and enforce everything versus trying to get people into treatment and recovery?
I would say that's the most surprising thing I've noticed, but the shifts have been pronounced. Now you hear people talk about overdose victims. Back in the day, by day I mean going back 20 years, they were people who used drugs were junkies, and police officers didn't really have any use for them. Now, when I talk to police, they're more excited about taking somebody that overdosed and getting them into a residential treatment program than they are, arresting somebody. There is, what we call compassion fatigue, where you have officers who are just going from scene to scene to scene, and it grinds on them. But I think because police officers deal with this on a daily basis, they understand that the old approach is not working, and I think they're some of the most compassionate people we interact with.
And we'll get to the community collaborators that are sitting around this table too, but Reverend Goldstein, can you talk a little bit about the faith-based them and why that is such an important,
We have a strong relationship with the faith-based community, and we also have developed a faith-based initiative where we find that recovery has a spiritual component to it, and many times people with mental health disorders and chemical abuse disorders are having spiritual trauma. And so we have developed a program where we partner people who are trained in theology with clinicians to better serve people that are living with these disorders. Also, I'm in the process of garnering a clergy handbook for ministers and church administrators so that they will have somewhat of a manual or a Bible that will lead them many times our spiritual leaders are the first responders. They're in contact with people at first, and so many of the spiritual leaders are not trained or have no idea how to respond and make a referral. So the clergy handbook will give them a guideline that will give them some clear directions on how to respond to people who are living with these disorders. It's important also that we talk from the pulpit about social issues, especially mental health and chemical abuse disorders. I was really surprised a few weeks ago when we were told that Cleveland was the second most stressful city in the country. And so people are living under some stressors. And so I think our clergy needs to talk about the stresses and also those people who are self-medicating, if you will, with drugs, that this is not the way and there is a better way. I'm hoping that we can build a strong network between clinicians and clergy. We're funding presently 9 agencies that are specifically geared with providing spiritual undergirding for people who need it in that particular area.
yes, thank you.